apprehension test for the anterior shoulder dislocation. The patient is positioned in supine with the arm in 90 degrees of abduction. The therapist laterally rotates the patient's shoulder. A positive test is indicated by the look of apprehension or facial grimace prior to reaching the endpoint. Anterior shoulder dislocation. The patient's positioned in supine with the arms in 90 degrees of flexion and medial rotation. The therapist applies a posterior force through the long axis of the humerus. A positive test is indicated by a look of apprehension. Special tests for the biceps tendon pathologies. First is the Speeds test. The patient is positioned in sitting or standing with elbow extended and the forearm supinated. The therapist places one hand over the bicipital groove and the other hand on the volar surface of the forearm. The therapist resists active shoulder flexion, and a positive test is indicated by pain or tenderness in the bicipital groove region and may indicate a bicipital tendinitis. Next is the Jorgensen's test for bicep tendon pathology as well. The patient is positioned and sitting with 90 degrees of elbow flexion and the forearm pronated. The humerus is stabilized against the patient's thorax. The therapist places one hand on the patient's forearm and the other hand over the bicipital groove. The patient is directed to actively supinate and laterally rotate against resistance. A positive test is indicated by pain or tenderness in the bicipital groove. Right. These are a couple tests following rotator cuff impingement. First, we have the Hawkins-Kennedy impingement test. The patient's positioned in sitting or standing. The therapist flexes the patient's shoulder to 90 degrees, then immediately rotates the arm. A positive test is indicated by pain and may be an indication of shoulder impingement involving the supraspinatus tendon. Next, we have the near impingement test. The patient is positioned in sitting or standing. The therapist positions one hand on the posterior aspect of the patient's scapula and the other hand stabilizing the elbow. The therapist elevates the patient's arm through flexion, and a positive test is indicated by a facial grimace or pain and may be indicative of a shoulder impingement involving the supraspinatus tendon. Rotator cuff pathology. The next test is the infraspinatus test. The patient stands with their elbow flexed to 90 degrees and the shoulder in 45 degrees of medial rotation. The patient then resists as the therapist applies a medially directed force to the forearm. Pain or weakness is an indication of an infraspinatus strain or tear. Okay, next is a supraspinatus test. The patient's positioned with the arm in 90 degrees of abduction, followed by 30 degrees of horizontal adduction with the thumb pointing downwards. The therapist resists the patient's attempt to abduct the arm. A positive test is indicated by weakness or pain and may be indicative of a tear of the supraspinatus tendon, impingement, or suprascapular nerve involvement. These following tests are to test for thoracic outlet syndrome. First, we have the Atkins maneuver. The patient's positioned in sitting or standing. The therapist monitors the radial pulse and asks the patient to rotate their head to face the test shoulder. The patient is then asked to extend his or her head while the therapist laterally rotates and extends the patient's shoulder. A positive test is indicated by an absent or diminished radial pulse and may be indicative of thoracic outlet syndrome. Next, we have the Allen's test. The patient's positioned in sitting or standing with the test arm in 90 degrees of abduction, lateral rotation, and elbow flexion. The patient is asked to rotate the head away from the test shoulder while the therapist monitors the radial pulse. A positive test is indicated by an absent or diminished pulse when the head is rotated away from the test shoulder. And lastly, we have the Roos test. The patient's position in sitting or standing with the arm positioned at 90 degrees of abduction, lateral rotation, and elbow flexion. The patient is asked to open and close their hands for 3 minutes. A positive test is indicated by the inability to maintain the test position, weakness of the arms, sensory loss, or ischemic pain. Test epicondylitis. We're going to start off with the Cosen's test. The patient's position in sitting with the elbow in slight flexion. The therapist places his or her thumb on the patient's lateral epicondyle while stabilizing the elbow joint. The patient is asked to make a fist, pronate the forearm, radial deviate, and extend the wrist against resistance. A positive test is indicated by pain in the lateral epicondyle region or muscle weakness and may be indicative of lateral epicondylitis. Testing the lateral epicondylitis test, the patient is positioned in sitting. The therapist stabilizes the elbow with one hand and places the other hand on the dorsal aspect of the patient's hand distal to the proximal interphalangeal joint. The patient is asked to extend the third digit against resistance. A positive test is indicated by pain in the lateral epicondyle region or muscle weakness and may indicate a lateral epicondylitis. The therapist palpates the medial epicondyle and supinates the patient's forearm, extends the wrist, and extends the elbow. A positive test is indicated by pain in the medial epicondyle region and may be indicative of medial epicondylitis. Tinel sign for the elbow. The patient is positioned in sitting with the elbow in slight flexion. The therapist taps the index finger between the olecranon process and the medial epicondyle. A positive test is indicated by a tingling sensation in the ulnar nerve of the forearm, hand, and fingers. And a positive test may be indicated of the ulnar nerve compression or compromise.